today. My name is Chefi Chaouacha. I'm postgraduate in gerontology from Sorbonne University in Paris, and I work as a GP for the Ministry of Health of Oman since 2014. Today, I would like to present my topic, Frailty profile of geriatric patients according to the multidimensional prognostic index, a cross-sectional study in primary care in the Sultanate of Oman. I will start with a brief introduction, then explain the methodology, next present the most important results, and finally, I hope to draw a conclusion, and I want to nudge few people. Like other countries, the Sultanate of Oman is undergoing a demographic transition as a result of the population aging. In parallel to aging, the prevalence of comorbidities such as diabetes, arthritis, cardiovascular disease, and age-associated conditions such as osteoporosis, dementia, polypharmacy, and social isolation increased. An older adult with such condition is at risk of being frail. In fact, frailty is a geriatric condition characterized by a decline in physiological reserve, leading to increase in biological, clinical, and social vulnerability to stressors responsible for increasing risk of developing negative health outcomes such as falls, functional decline, hospitalization, and increased mortality. Frailty is a multi-dimensional state. In other terms, frailty is related to multiple risk factors, such as being female, increasing age, comorbidities, cognitive impairment, malnutrition, polypharmacy, and social isolation. A multi-domain assessment will be therefore the best approach to identify risk factors of frailty, and the Comprehensive Geriatric Assessment, CGA, is the gold standard diagnostic tool to effectively identify frailty and examine the clinical risk factors for frailty in elderly people. Frailty is a dynamic condition preceded by pre-frailty, which is a clinical silent process that predisposes individual to frailty. However, frailty can be improved by early detection and management. The prevalence of frailty in the Sultanate of Oman is unknown, and the aim and objective of our study was to determine the prevalence of frailty and identify correlated factors among older adults attending primary healthcare settings. For this purpose, we conducted a descriptive cross-sectional study included 197 participants aged 65 years and more who attended Wadi Ma'awil Primary Health Center located in the region of El Batina in northern Oman. To describe frailty and determine its risk factors, we have collected socio-demographic and clinical parameters of the study population and performed the multidimensional prognostic index, MPI. MPI is an instrument that includes information from 8 different domains of the CGA, or Comprehensive Geriatric Assessment, namely the basic activities of daily living, using the CATS index of independence in activities of daily living, or ADL, the independent complex living skills using the Lawton Instrument Activity of Daily Living Scale, or IADL, cognitive status, for which we have used the Short Portable Mental States Questionnaire, the risk of developing pressure injuries, for which we have used the Exton-Smith Scale, the nutritional status, for which we have used the Mini Nutritional Assessment Short Form, or MNA, the comorbidities burden, for which we have used the Cumulative Illness Rating Scale, and we have assessed the number of drugs usually taken by the patient, and finally, the cohabitation status. The MPI score ranges from 0 to 1, and the candidates were categorized as non-frail or MPI-1 for score ranging from 0 to 0.33, and pre-frail or MPI-2 for a score ranging from 0.34 to 0.66, and frail or MPI-3 for score ranging from 0.67 to 1. Our main result, I shared our main result. So our study showed, as its notes in the first figure, that pre-frailty and frailty were highly prevalent. So 31.5% of study population were pre-frail, while 21.7% were frail. We will note on the next chart that prevalence of frail increased with age. Also, cardiovascular disease, diabetes mellitus, and polypharmacy, defined by the use of 5 drugs or more, increased across frailty profiles, and they are more prevalent in frail participants. Multinomial logistic regression was used, as shown in the table below, to determine the association between baseline characteristic and frailty status. So older age was statistically associated with frailty status. Women were approximately 3 times more likely to be pre-frail than men and 7 times more likely to be frail. Older adults with cardiovascular disease were approximately 2.5 times more likely to be pre-frail and 3 times more likely to be frail than older adults with no cardiovascular disease, while people with diabetes were 1.6 times more likely to be pre-frail and 1.3 times more likely to be frail compared to people who were not diabetic. There has been a gradual increase in risk of being pre-frail and frail as number of used drugs increased from less than 5 through 5 to 9 and to more than 9. The next table illustrates the association of the 8 MPI domains that I have mentioned earlier, defined as independent risk factors of frailty. The table shows that social status did not differ significantly among frail groups, as 97.5% of the participants lived with their families. Living in a family appears to be a protective factor among the different age and gender groups, while severe functional decline, cognitive impairment, malnutrition, and comorbidities burden were demonstrated to contribute the most to frailty. To conclude, frailty was common among elderly patients attending primary healthcare settings. Older age, female gender, cardiovascular disease, diabetes mellitus, polypharmacy, functional decline, comorbidity burden, and malnutrition can be used as indicators of frailty. Primary healthcare holds a central position in promoting health and preventing diseases. Thus, primary care providers are well placed to play a key role in screening for frailty and identifying its modifiable risk factors for an early intervention. In addition, recognition of frailty might help primary care physicians provide appropriate interventions and optimize management of coexisting conditions that might contribute to frailty. I would like to express my deepest appreciation to Professor Yahya Al-Farsi for his contribution to the study. I'm also grateful to Dr. Buthena Al-Zaabi, Dr. Nazish Mimoun, and the nursing team for their contribution to this work. Thank you very much for your listening.